Good morning. My name is Sameh Mezri and I'm an ENT resident at the Military Hospital of Tunis. It is my pleasure to present to you today our study titled Coexistence of Tuberculosis and Malignancy in a Single Lymph Node, a Diagnostic Challenge. The co-occurrence of tuberculosis and malignancy has been documented, particularly in regions with high prevalence of tuberculosis. Nevertheless, their simultaneous presence within a single lymph node is exceedingly rare. The initial observation was made in the axillary lymph nodes of a patient diagnosed with breast cancer. Subsequently, a handful of cases have been documented in the medical literature. These instances have also involved the cervical region. So the purpose of this study was to discuss through our cases clinical features and treatment options of concomitant tuberculosis and malignancy within cervical lymph nodes. Our study included 10 patients who underwent treatment for simultaneous tuberculosis and malignancy within the same cervical lymph nodes at our ENT department of the Military Hospital of Tunis. The cases were retrospectively reviewed. We collected through medical files demographic data such as age, gender, history, clinical features, tests, imaging, treatments, and outcomes. The study included 10 patients, 5 men and 5 women. Their mean age was 47 years. 3 patients had a history of previously treated lymph node tuberculosis. 2 patients were undergoing treatment for tuberculous lymphadenitis. 3 patients were initially diagnosed with cancer. 2 of them were undergoing cancer treatment, while the 3rd patient had completed cancer treatment and was in remission at the time of the concurrent diagnosis. The remaining 3 cases did not have a prior diagnosis of either cancer or tuberculosis. All the patients who were treated for tuberculosis or cancer had cervical lymph nodes before starting treatment. Among these, 3 patients developed new lymph nodes, while 1 patient exhibited persistent lymphadenopathy despite undergoing treatment. As for the remaining 6 patients, all presented with cervical lymphadenopathy. In 5 cases, additional symptoms such as dysphonia, dysphagia, or nasal obstruction were observed. On physical exam, lymph nodes were mainly located in level 2 and 3 of the neck. They were bilateral in 3 cases. The tuberculin skin test was performed in 5 cases, showing positive results in 3 of them. Neck ultrasound was performed in 5 cases, revealing the following findings. Bilateral lymph nodes were observed in 2 cases. Irregular margin were noted in 3 cases. Cortical thickening and absent fatty hilum were present in 3 cases. Areas of necrosis were identified in 3 cases. Microcalcifications were observed in 1 case. CT scan was performed in 7 cases, demonstrated necrotic appearing lymph nodes in 5 cases, as illustrated in the CT scan on the left. Additionally, mediastinal lymph nodes were observed in 2 cases. Furthermore, 1 patient exhibited evidence of miliary tuberculosis on CT scan. In 4 cases, both tuberculosis and cancer were detected following lymph node dissection. In 4 cases, the primary tumor and its histological type remained unknown until lymphadenectomy was carried out. However, in the remaining 2 cases, the diagnosis of tuberculosis was confirmed by a positive tuberculosis PCR test in patients who exhibited cancer cells on histological or cytological exam. Cytology alone was insufficient for the diagnosis of both cancer and tuberculosis. In 3 cases, the diagnosis was laryngeal cancer. Thyroid cancer was identified in 3 cases. Lymphoma was diagnosed in 3 cases. Additionally, nasopharyngeal cancer was observed in 2 cases. Treatment included total laryngectomy, neck dissection, radiochemotherapy in laryngeal squamous cell carcinoma, total thyroidectomy, neck dissection, radioactive iodine therapy in papillary thyroid carcinoma, total thyroidectomy, neck dissection, radiotherapy in medullary thyroid carcinoma, and radiochemotherapy in undifferentiated nasopharyngeal carcinoma and lymphomas. In our study, all patients remained free of cancer after a minimum follow-up period of 5 years, except for 1 patient diagnosed with nasopharyngeal cancer and another one with non-Hodgkin lymphoma. The treatment regimen consisted of rifampicin, isoniazid, pyrazinamide, and ethambutol for a duration of 2 months, followed by therapy with isoniazid and rifampicin alone. On average, the duration of treatment was 10 months. Healing was defined as the complete disappearance of lymphadenopathy. No adverse effects were observed with the tuberculosis treatment regimen. However, 1 patient succumbed to miliary tuberculosis. Our study benefits from looking at previous research, which helps us understand better how tuberculosis and cancer can be found together in lymph nodes in the neck, and the difficulties doctors face in diagnosing them. The relationship between tuberculosis and cancer remains poorly understood. Some theorize that cancer may provide a favorable environment for dormant tuberculosis bacteria, while others suggest that the tumor-induced immunodeficiency may promote the coexistence of both diseases. Diagnosis concurrent tuberculosis and cancer is often delayed due to their similar clinical symptoms. Signs of nodal tuberculosis often include swollen lymph nodes, weight loss, and night sweats. These symptoms are commonly seen in malignancies as well. In cases of synchronous tuberculosis and head and neck cancer, treatment failure in either condition commonly leads to discovery. Rare instances of tuberculosis coexisting within the same lymph nodes as undifferentiated carcinoma, laryngeal squamous cell carcinoma, and papillary thyroid carcinoma have been documented. Imaging techniques frequently fail to differentiate between tuberculous and metastatic lymph nodes. Although combined fine needle aspiration and PCR for Mycobacterium tuberculosis detection are recommended when tuberculosis is suspected in cancer patients, histological examinations remain the gold standards for confirming concurrent tuberculosis and malignancy. However, granulomatous lesions, including caseating and necrotizing granulomatous tissue, can occur in tumors such as lymphoma, squamous cell carcinoma, and nasopharyngeal cancer. Treatment of tuberculosis in cancer patients lacks standardized protocols and requires multidisciplinary discussion. Monitoring for drug interactions and side effects between anti-tuberculous medications and cancer treatment is essential. The concurrent presence of cancer and tuberculosis infection within the same lymph node can mislead and delay the diagnosis and treatment of either condition. This circumstance may be particularly considered in regions with a high prevalence of tuberculosis. Tuberculosis infection occurring during or after chemotherapy can further complicate the differential diagnosis between resistant tuberculosis and recurrent malignancy. The definitive diagnosis relies on the patient's medical history, physical exam, tests, and imaging. In certain cases, lymphadenectomy may be warranted. Ultimately, treatment may necessitate close collaboration among infectious disease specialists, ENT, and oncologist. Thank you for your attention.